Paul, dear colleagues, and my very effective palliative care team. I'm always happy when I am with my team. In palliative care, team spirit is the main strength to provide the holistic care for the cancer patients in every aspect. May I please welcome you to today's lecture, my palliative care lecture module 4. Today I'm going to present on the necessity of morphine in our prescriptions for the highest optimum pain management, one of the most effective pain management tool in pharmacology and also clinical practice. Next slide, please. Okay, so morphine, most of us, all of us knows actually today who are present in this lecture, that it is a drug which is called opiate analgesic, and it is extracted from a flower called poppy flower. There is a photo here, I tried to get it from internet, which is showing the one or two colors with this poppy flower. There are different colors of poppy flowers actually available in the whole world. There are so many countries like South America, Eastern Asia, Africa, and where not, USA, Australia, all the places. There is a number of places who are famous for agriculturing this poppy plant. The reason is that it can give us the core element to produce this drug morphine in the laboratory. Next slide, please. So, as discussed, morphine is a type of opioid. It is extracted from opium poppies in a laboratory. Next slide, please. The morphine molecular structure can be of different because of different compound things can be added to the basic morphine molecule. The pharmacologist can more enlighten us with this, but as a like in a short, we can say that morphine is chemically compound of carbon, hydrogen, nitrogen, and oxygen. One molecule of morphine can be called as C17H19NO3. There is a sort of two-dimensional photo in this slide. So we can understand that this is the core morphine molecule. You can add in the laboratory other compounds or other to make another different type of morphine. Next slide, please. Okay, so why are we talking about morphine with importance in the palliative care management of cancer patients to minimize the cancer pain? The reason is that most of the time pain is underreported and pain is undertreated. The physicians are also not comfortable to prescribe morphine. Just imagine like why the pain is underreported and undertreated. So if when in the daily life we are hit by something accidentally or like anyway, so do we go to the doctors every incident? No, we wait. All of us, even being a medical personnel, we wait. We think that okay, maybe this pain will go away today, so tomorrow it reduces and the next day it goes away maybe, but sometime it does not go. In the first day the incident of pain, the second day it increases or persists, and then third day we decide no, this is the day we should see a doctor and get a prescription to minimize this pain. And why pain is undertreated? This is also the reason, like when the clinical practitioners, when they ask a person in the clinic or in a hospital like about the pain, the most of the time the person who is having the pain is describing in a way that we are unable to to measure the pain, like how much is the context of the pain or the amount of the pain or the degree of the pain. That is another thing, because of sometime maybe we don't have training, sometime we don't have the time. We think that there is so many patients are sitting in the OPD, so let me just listen to the patient and prescribe da 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 da. But this should not be in this way. When a patient or a person complain to us for pain, we must go deep to it. We must use those tools of pain assessment, WHO tools, and the other tools of the amount of pain, the degree of the pain, and the multitude of the pain, and then we can have an idea like how much pain that person has, and then we can make a good prescription and plan also to minimize that pain. Next slide, please. May we go to the next slide, please? Hello? Yes, thanks. Okay, so if we can just go back a little bit, all of us, we know that the definition of pain, there are so many different definitions of pain. So pain is a somatic and emotional sensation that is unpleasant in nature and associated with actual or potential tissue damage. If we think about the classification, there are also many different types of classification of pain, each arising through unique mechanism. Maybe it can be sharp pain or pricking pain, thermal pain, aching, or throbbing pain. If we just think about the origin of the pain, it can be somatic, visceral, neuropathic, psychosomatic, referred pain, or illusionary pain. Pain can also be classified like acute pain of short duration, chronic pain in nature for long duration pain. Next slide, please. Hello. Can we please go to the next slide? Thanks. Okay. So, again, the pain pathway. To understand pain and morphine, we have to a little bit revise the pain pathway. We have to remember that in a few seconds back I talked about that we wait for the pain. After the pain starts, we wait to absorb the pain, to get, okay, it will go away. Why? Because we have like there is physiologically a pain reducing mechanism the nature has got or God has given to our body, which can automatically reduce some extent of pain. Yeah. So that is called an endogenous mechanism of pain reduction. Yeah. There are some neurotransmitter, some nerve ending functions, so they can automatically reduce the pain. So how? Because in pain pathway we can see that there is the source of the pain. Suppose if you think about the, like somebody has a pain in the hand or the finger, if you can see at the slide, then we will understand the pain if that pain, sense of pain or the news of that pain, if we can say easily, it goes via the neurons, the nerve fibers to our brain. There are several centers in the brain to catch that pain sensation from the periphery. If the pain after being happening on any part of the body, it goes through the spinal cord to upstairs in the cerebral cortex, like in the midbrain or pons. Then those are the parts of the brain. Then there are centers of understanding, the receptors for to understand that, yeah, okay, there is a pain now. The person can feel the pain then. So if you see at this chart here, a photo here, you can see so there are four steps of pain to be understood in the brain. One is transduction, where the source of the pain is making pain in the periphery of the body, and then this sense of the pain, transmission, the process by which it goes to the spinal cord. There is a place called dorsal root ganglion in our spinal cord, where that sense of pain is modulated, which is the process is called modulation, and then through the afferent fiber it goes up to the cerebral cortex, to the pain center, whereby we can understand, okay, now I'm getting pain. So look at the diagram please here in this slide. So somebody is getting a hit in the thumb or in the palm of the hand, and which is called the transduction, and then it is going through the nerve fibers to, in the middle you can see the spinal cord. There is something called dorsal root ganglion, where the pain sensation is modulated by the process modulation, and then afferent fibers take that pain sensation up in the cortex, where is the red color sign is written pain center, and there the perception of pain. Next slide please. So shortly, how does morphine act to stop this pain sensation? So in one sentence we can say morphine blocks pain messages from transmission along the nerve fibers to the brain. Next slide please. Okay. Now let us just remember, we have mostly know the receptors. Just to revise a little bit, opiate receptors are three types mainly: mu receptor, kappa receptors, and delta receptors, which are situated in the periphery, in the dorsal root ganglion of the spinal cord, and in the supraspinal region. These receptors are responsible for pain modulation. So opiate drug morphine, it interacts with the opiate receptor, these three types of receptors in the nerve fibers, mu, kappa and delta receptors, to produce analgesia, to inhibit the pain sensation by two processes mainly. One of them is called hyperpolarization of neurons and inhibition or depression, the release of neurotransmitter associated with transmission of pain. We will talk about few neurotransmitter following, but let us go on. So depression or inhibition of pain sensation occurs within the dorsal root ganglion of the spinal cord, where the primary pain fibers which transmit pain sensation from the periphery, then to synapse, then with the neurons, the nerve fibers which transmit pain to the higher centers in the cerebral cortex. Next slide please. We are going a little bit through the mechanism of analgesia. So activation of the analgesic mechanism results from an interaction between specific neurotransmitters as enkephalin, serotonin, norepinephrine, and specific receptors are located on the neurons, as said just in the previous slide, which these neurotransmitter substances are released in the neurons which transmit the pain. So the spinal analgesic mechanisms can be activated by either pain or non-painful sensation or any other sensation arriving from the periphery or by the supraspinal mechanism. Next slide please. Now what is this supraspinal mechanism of analgesia? It's very interesting. Supraspinal mechanism originate in the specific structures within the brainstem that include the periaqueductal gray matter, lucus ceruleus, and nuclei of the medulla. So this mechanism of the brainstem. So we know there is gray matter, white matter of the brain. It is formed by gray matters and white matters, and then locus ceruleus. What is this? These are some blue spots on the cerebral cortex up to the pons and medulla oblongata down, which can like stimulate the release of noradrenaline in the blood system. These systems are activated either by ascending pain impulse through the afferent fibers or by the higher centers such as the cerebral cortex or hypothalamus that in turn activate the spinal analgesic system. Next slide please. So, there are basically three systems associated with the activation of the supraspinal mechanism, which are called the opioid system, adrenergic system, serotonergic system. The opioid system is associated with the release of the endorphins, adrenergic system associated with the release of the norepinephrine, and serotonergic system is associated with the release of serotonin. Next slide please. When this endogenous analgesic system fail to control the pain, analgesic drugs are required at that point to enhance the endogenous system of pain inhibition. Opioid drugs, as this morphine which we are discussing today, interact with opioid receptors. You remember those receptors, mu, kappa and delta receptors, and produce analgesia by the same mechanism as enkephalin, that is hyperpolarization and the deep inhibition, hyperpolarization of the neurons and inhibition to depress the release of neurotransmitters which are named in the previous slide associated with the transmission of pain. In addition, morphine can also interact with opioid receptors located in the supraspinal structures and activate the supraspinal system. Adrenergic drugs which interact with specific receptors also produce analgesia, and it has been suggested that morphine interacts with the adrenergic system to produce this analgesia. Next slide please. So, last 2 years we are in Sankatana all together, our colleagues, most of us already know the morphine can come in different formats. We are just going to have a look at those forms of morphine. Like we know we have tablet morphine or capsule morphine. Then there are other morphines are syrup morphine, which we don't have. Injection morphine in our pharmacy we don't have, meaning I'm saying about in our pharmacy we are still to procure this syrup morphine. We only have tablet morphine at this moment, 10 milligram of each tablet in our Sankatana pharmacy for the cancer patients. And then we also see that there are injection morphines and suppositories morphine. I am talking about morphine, I am not talking about other opioids. There are so many types of opioids, that is not in our lecture today, but we are talking about specifically morphine. So, the best route of administration in palliative care management of cancer patient, in books are written that best route of administration of morphine is per oral, because morphine is best absorbed through oral mucosa and gastrointestinal tract mucosa. Next slide please. Again, morphine can be short acting morphine and long acting morphine. Short acting morphine lasts for 2 to 4 hours in the system after every dose. Most people start on a short acting morphine tablet or liquid. This is the guideline for palliative management of pain for cancer patient. It's very important, this part, that most patients of cancer, when we start in a morphine naive person, we have to think that this is a morphine naive. We are going to start morphine for a patient having pain. So, let us prescribe a short acting morphine, mostly the liquid morphine. This is because it is easier and quicker to adjust the dose and also good for absorption, and this is the benefit for the patient. Long acting morphine last in the system for 12 to 24 hours per dose. Patient will take it either once or twice a day. If taking it twice a day, to take it in the morning and at evening. For example, at 8 a.m. in the morning maybe, and then 8 p.m. in the evening. In this slide, I have put a double dot to say a statement. It is important to take morphine regularly, even if patient doesn't feel pain. The slow releasing tablets or capsules can take up to 48 hours to give you a steady dose. So if the patient stops taking morphine and then restart again the next day or next to next day, the morphine will not work so well. Next slide, please. So liquid morphine comes as a syrup or as a powder to dissolve in water. It is easy to adjust doses according to the patient's need. This statement is also very important. Morphine to be provided to the patient according to the patient's need, individual patient's need. Each cancer patient have different need of pain management. Next slide, please. Another thing we are going to discuss now, this definition of breakthrough pain. In palliative care pain management for cancer patients, this term is very, very important to understand breakthrough pain of a patient. So, when a patient we prescribe on morphine, the patient is taking morphine regularly. So, in between the patient's taking morphine doses, he can also have a pain release of the start of pain. He can also start another pain, episode of pain. If it comes in between the doses of morphine, what will the patient do? Will he just continue with the regular doses? It's not ideal. So we have to talk about breakthrough pain. This is the breakthrough pain which arises between the doses of morphine. It is called the breakthrough pain. So this breakthrough pain needs to be dealt with by doses of morphine which is called rescue dose of morphine. So rescue dose of morphine is usually calculated 25 to 50% of the regular dosing of morphine. Next slide, please. In palliative medicine, dealing with pain of cancer patients, morphine to start in a go slow approach. Start as little as 5 milligram per oral 4 hoursly, then to 10 milligram per oral 4 hoursly, and increase doses slowly according to the need of the patient. I am repeating, according to the need of the patient, and individual patients have always individual needs. So the patient's assessment and follow-ups are very, very important. We have to remember morphine is best absorbed in oral mucosa and GIT, gastrointestinal tract mucosa. Next slide, please. Morphine usually is highly discussed and also less used. Morphine, I am telling it again, highly discussed among the healthcare professional, even the community, in the newspapers and so on, but less used. Why? The reason is there are some misconception all over the world who needs to use prescribe morphine, or who needs to use morphine, who needs to procure morphine in different levels. The reason of misconception, people think morphine will make addiction, it will make permanent drowsiness of a person, it will make respiratory depression, it will make mental confusion. it will hasten the people's death and never stop. Once started, only reserved, morphine is only reserved to use in the end of life. These are some of the misconception is going through for a long time regarding uses of morphine. Next slide, please. What is the actual fact? We are going to look into it now about morphine. The most common side effects, and there are rare side effects. Common side effects of morphine using persons are observed mostly, but the rare side effects, I can say, almost never observed. Why I am saying this? There are very rare occasions whereby the healthcare professional, after prescribing morphine, will find a report from the patients that they have those rare adverse effects. Let us go through them, please. The most common adverse effects are somnolence, dizziness, nausea, vomitus, constipation. So, these are the commonly observed side effects in persons whom are prescribed morphine. So, these are the things needs to be informed to the patient that okay, today we are starting morphine for your pain management. Please expect there might be dizziness, sleepiness, nausea, vomitus, constipation, and please, you know, we have drugs to battle with those side effects. We have stool softener, we have propulsive stool, those medication, we have antiemetics, we have medication to deal with these common side effects. So, we have to be careful of informing the patient the details of common side effects of morphine. And if we inform the patients the common side effect and also the relatives, it will be easy for a patient to understand and not to be surprised when these common side effects come while he or she is using the morphine. Then what are the rare side effects for morphine? There can be itchiness of skin, there can be mental confusion. Very rare, they are very less reported side effects. Next slide, please. Now, when to contact the palliative care team from the patient and the family? The doctor and the nurses will go through the possible side effects. They will monitor the patient during treatment and check how the patient is doing with morphine at follow-ups appointments, and then advise the patient to contact the palliative care team if there are those severe side effects which are very rare. I am telling it again, very rare side effects. Those are the severe side effects. They are very rarely reported. Next slide, please. Now, the withdrawal syndrome, taking morphine for weeks or months, it can develop a physical dependence because it's an opiate medication. This will cause withdrawal syndrome if only when the drug is stopped suddenly. If some patients, few patients being observed, they decide to stop any drug, not only morphine, by themselves. It's not unusual. All of us, we know it's not an unusual occasion. So, if they suddenly stop the morphine, it can cause the withdrawal symptom or withdrawal syndrome. If you want to stop morphine, the prescriber should stop by decreasing the doses of morphine slowly, gradually by decreasing the doses. Next slide, please. To be aware that in severe morphine adverse effect, if the patient has only respiratory depression or severe circulatory depression, then only antidote should be used. It is written in the books. It is called naloxone. Most of us, we are aware of it. Naloxone is a specific antidote for morphine. The recommended dose is start from 0.4 milligram to 2 milligram IV every 2 to 3 minutes as the need of the patient. Next slide, please. Okay, dear colleagues, am I audible to you? Okay, so there is a good practice in palliative care management. It is a part of the practice, good practice, that whenever the prescriber, the healthcare provider prescribes morphine for a patient and the patient goes to the pharmacy, she or he gets a handout. Here I have structured just a specimen. I have previously informed Mepal about this thing. We will discuss it elaborately in future on it. If possible, this type of handout which shows morphine information from pharmacy to every patient, to print, we can print it if we all agree, our team through Mepal and our other colleague specialists and the other colleagues in the palliative care team. It is good, we can give that handout to the patients, which is a leaflet, a paper of morphine information from the pharmacy. It shows some statements here, like if you can see it, if you have any question and problem after using morphine, please contact the phone number of the clinic, the email number of the clinic who is prescribing the morphine, and the dosing hours of morphine, like example 6 a.m., 10 a.m.,